not only is it just a chronic progressive issue, but it impairs function. So a lot of people end up coming through to the clinic and they're fine, they're working, everything's fine, but they feel as though they're not remembering things well. So it's only classified as dementia if it impedes normal function, right? Then what are these non-communicable diseases, right? So these are diseases that are spread through infection. So we know there are a lot of diseases where you can get passed from one person to another, but these have to do with lifestyle. So we usually refer to them as lifestyle diseases that are related to essentially unhealthy behaviors, right? Next slide. So if we look at the idea of dementia, it's actually an umbrella term for several different entities, disease entities. So the one that we're most aware of, or the one that we deal with the most, or the ones that, we think of when we think of dementia is Alzheimer's disease, right? So it's even referred to as Alzheimer's disease. And this accounts for around 60 to 70% of dementia cases. And this is kind of why it's become synonymous with dementia itself. But there are different kinds. There's also what we call vascular dementia. So, and then there's frontotemporal dementia, Lewy body dementia, and other dementias that we won't go into this presentation. But the Alzheimer's disease, what starts it off is usually the memory issue. So people present first early on with memory problems, and it's because of the area where the brain actually encodes for memory starts to die off first. We're going to go a little bit into how it happens, but essentially the thought behind this is that there is deposits of what we call tau filaments. So these protein deposits that basically stop the communication from one cell to another. And how actually Dr. Alzheimer's, the person that discovered it, saw was that there was a patient who came to her with memory issues. And when the patient eventually died, they did an autopsy and they found that under the microscope, the brain was filled with these protein deposits, especially around the part of the brain that encodes for long-term memory. And so you have these protein deposits, and then eventually the other parts of the brain also start to die off. But it starts off with memory and then executive function, etc., etc. Now, the next one is vascular dementia. So vascular dementia has to do with dementia that happens after one has had a or several strokes, right? So what happens with a stroke is that you get blockage of an artery, so you don't get blood supply to that artery. Now, it's like with a foot. If you don't get blood supply to a foot or finger, that part eventually dies off. So with vascular dementia, you get cutting off of blood supply to a specific area of the brain. And because of that, you then lose that part of the brain. Now, if this happens many times, you basically lose chunks of brain, right? It actually, we'll see a scan later, but it looks like your brain has basically been bitten out by things, right? And because of that, you then start developing different kinds of executive fallout. So you're now no longer able to do certain things depending on which region is most affected first. But usually it doesn't present with the prominent memory things like the Alzheimer's dementia. It usually depends on where the issue was, right? Then the next is frontotemporal dementia. So this one, there's memory issue, but there's also frontal executive function that is a problem. So the frontal lobe of the brain, which is basically behind your forehead, this actually helps to develop appropriateness behavior and executive function. So things like the fact that after giving a round of applause to stop, that's your frontal lobe coming through. Appropriately using the bathroom, appropriately speaking to people, saying things at the right time, filtering out things, even your personality is housed in that frontal lobe. So with frontotemporal dementia, patients or family members will often complain of their family members having changes in personality, dysexecutive function. So we actually refer to them as frontal in the sense that they've lost the ability to be appropriate, to act appropriately. And there are certain things that we test where we call them frontal lobe syndromes, where somebody is showing that they basically have loss of their frontal lobe. So for example, there's something called an applause sign where we'll randomly in a ward round, someone will clap 3 times. And if anyone did that in front of you, you'd just think, okay, what's happening? But because this person has lost their frontal lobe capacity, once you clap 3 times, they continue clapping throughout until you actually have to stop them. So all of that dysexecutive function usually happens with frontotemporal dementia. And then they also usually have speech issues very, very early on, as opposed to Alzheimer's, which usually happens later. So that's frontotemporal dementia. And then Lewy body dementia is associated with movement issues. So they have movement disorders. So involuntary movements that come early on before the memory issues start coming through. So we can see that to call something dementia, there's many, many different kinds of dementia. But the one we think of the most is Alzheimer's disease. So we can go to the next slide. So now what we need to discover is who actually gets dementia. What are the demographics behind that? So the most common occurrence of dementia happens after the age of 60. The thought behind this is that after the age of 60, you've had more chance for your brain to actually accumulate these tau proteins, or the proteins that I was speaking of earlier. But also you have more lifestyle diseases. And this is the whole point of what we're speaking about today. So once you've accumulated those lifestyle diseases, you're then more likely to develop the dementia itself. The prevalence increases from around 6% in your 60s to around 30 to 40% by the age of 80. So the longer people stay alive, the higher the risk is for them developing dementia. It also has to do with what we call the blood-brain barrier. So essentially, there is holding off of communication between the blood elsewhere and the blood in the brain. So once that communication is severed, or once that safeguard is severed, then you have more chance of these proteins coming through. And once these proteins come through, then you're able to, like I said, have those deposits in the brain. So it's thought that as you grow older, the blood-brain barrier is actually compromised, and the longer you stay alive, it actually becomes an issue. The other thing is females are more affected than males, but males tend to be affected at a younger age. Now, my grandmother suffered from dementia before her death in 2022. And with her, the signs probably came in around her 70s. It's difficult to say because it was a very insidious onset. But females tend to be affected more. They also tend to present earlier. But the males tend to be affected way younger. The thought behind this is that males tend to engage in more risky behaviors, as well as smoking, which compromises that blood-brain barrier and increases risk of that protein deposit, but also increases the vascular risk factors, which we'll see is a very prominent thing. Now, the other thing about dementia in South Africa is that we may be underdiagnosing it, because not a lot of people actually think of it as a disease, but think of it as a part of aging. So you'll see that even our patients actually present late. They present in what we call the catatonic state. So this is when they're not able to move much anymore, they're bedridden, and that's when family members actually bring them through. So they bring them through because my family member isn't eating, or my grandmother isn't drinking, or et cetera, but in actual fact, the signs have been there for way longer. Yeah, you can go to the next slide. So this association with lifestyle, right? So there are a couple of mechanisms that are thought to be what happens in dementia. And the first one is with insulin desensitization. Now, whenever we think of insulin, we think of diabetes, which is a good association. So with insulin desensitization, essentially, insulin helps sugar get into our cells. So the example that is often used is the example of a lock and a key. The insulin is the key that opens up the lock so that the sugar can go in. But at some point, because of lifestyle, oftentimes because of weight gain, somebody changes the lock. So you develop insulin desensitization. So the key is actually no longer able to open the locks. And because of that, you are unable to control the sugar. So this is how you then develop diabetes. Now, with this insulin desensitization, it damages blood cells or the blood vessels themselves. It also damages this blood-brain barrier. So with this desensitization, then and this damage to the blood-brain barrier, you have more of these protein deposits in the brain. But the next thing shows us the vessel injury. So if you think of your blood vessels like a hose pipe, right? Every time there is something that is not good for the blood, let's say, it irritates the lining of that vessel. And as you irritate the lining of that vessel, other cells come through to basically close up where that irritation has happened. Now, if you close up where that irritation has happened, imagine putting Play-Doh inside a garden hose, right? So if you put Play-Doh inside the garden hose or into a pipe, you've closed off a little bit of that space. And as you do that over time, you eventually close off the pipe itself. So you close off the vessel itself. And as you close off that vessel, you're unable to get blood flow. And when you get poor blood flow to a place, then you get these micro strokes or these small strokes that happen, especially in the small blood vessels. Now, remember I described that every time you have cut off of blood supply to the brain, you lose that part of the brain. So you have these small blood vessels that are closed off because there was vessel injury, and it's closed off, and then you lose that part of the brain. Now, those small bits, those dots basically in the brain start going missing. And because of that, you then also develop a pro-inflammatory state, right? So the vessel injury tells the other parts of the body that they should be helping out. And because of that, there's inflammation, and that inflammation also basically causes the release of certain hormones like cortisol, etc., which worsens that insulin desensitization. But also this pro-inflammatory state is thought to compromise that blood-brain barrier. Then you have those tau filaments and protein deposits in the brain, and that's how you eventually get Alzheimer's. But with the vascular dementia, it's usually because of small strokes or even big ones, because of the vessel injury initially and then closing off of those vessels. So we can go to the next slide. So the vessel wall is damaged, like I described, right? So that vessel wall is damaged, and that changes the blood flow to the brain. So it reduces oxygen to the brain, right? And this precipitates the aggregation of protein deposits in Alzheimer's. So in vascular dementia, it has to do with the vessels being closed off completely. But with the Alzheimer's disease, there's the aggregation of protein because of the changes in flow to the brain. So anytime the oxygen to the brain is compromised because of vessel issues, it basically puts us at greater risk for Alzheimer's. We can go to the next slide. So this is a nice picture to basically look at the 4 biggest players of lifestyle diseases and how they actually contribute to the development of Alzheimer's. So if you look at the top left corner, you have hypertension, right? So with hypertension, as I was describing, if you have a pipe and you've closed off a part of that pipe, you're not getting as much of the fluid through. So you get what we call hypoperfusion, meaning less perfusion. Then you get ischemia, which basically means you've got low blood flow to that place, and that causes cerebral hypoxia, basically lack of oxygen to the brain, and that breaks down the blood-brain barrier. So that's BBB is the blood-brain barrier that I was describing. If we look below that, obesity, that insulin resistance, because of the fat, your fat cells actually are able to secrete insulin-like substances that basically change the locks of the insulin, like I was describing, change the locks of the sugar metabolism as I was describing, right? So dementia, the chances are actually increased when your BMI is greater than 30 in the middle ages. And this is because you've got a longer time of insulin resistance, right? If you look on the bottom right corner, diabetes. So once again, the insulin resistance, and then you have these high sugars with the inflammation, and then once again, the vascular damage, right? And up there, the dyslipidemia, so your high cholesterol. So you've got breakdown of your blood-brain barrier. You've got those protein deposits. Those are the tau and alpha-beta protein deposits. And then you have that inflammation of the nerve cells themselves. So we see that vessel health is closely aligned to brain health, because your brain actually takes up a lot of the blood flow. It needs a lot of oxygen. It's a high metabolic area because it's constantly doing so much. So because of that, if you compromise that, then you're basically creating issues, right? So once again, going through it, so the dyslipidemia and obesity, it increases, if we go to the next slide, the dyslipidemia basically being your high cholesterol, and obesity, I put them together because they kind of do go together. And it increases the protein deposits. Then you have poor nerve cell function. Now, interesting, it's not just when your proteins are high, but it's also just with fatty foods. So eating fatty foods basically causes inflammation, which could lead to later insulin resistance. So it's a it's a risky situation to indulge in these, especially on a consistent level. Next slide. So depression is an actual interesting one that we don't often think about as a non-communicable disease, but it actually is now starting to form part of what we call lifestyle diseases. Even though it is a mood disorder, and it's because it contributes so significantly to lifestyle diseases. So I like this image so much because it shows how depression is actually linked to all of these things, right? So if we look at the first arrow going down, it leads to vascular injury. How? Because when you're depressed, you're likely to either take in things that aren't as good for your health or use substances to cope. And because of that, usually you develop vascular injury that can lead to vascular disease, which causes these frontal striatal abnormalities. So the issues in the frontal lobe and also in the area of the striatum, which basically worsen that, right? So that almost creates a feedback loop to each other, right? So as you lose your frontal lobe and all of that, your ability to regulate your emotions also becomes worse, which worsens the depression, which worsens the chances of you engaging in activities that would cause vascular damage, right? Then the second arrow from the bottom, these alteration in nerve growth factors. Because depression puts you in a state where you're releasing inflammatory substances from the body, because basically it has triggered your fight or flight response consistently, right? So you develop these pro-inflammatory changes, your nerve cells are no longer functioning properly. And because of the increase in your steroid release from the body, because it thinks it's in a fight or flight response, you can actually develop atrophy or like shrinking down of what we call your hippocampus. And your hippocampus is the area of your brain that actually encodes your memory. So if you have hippocampal loss, then it means you've lost memory essentially. And it also increases the chances of you developing these plaques in the brain because of the pro-inflammatory changes, that blood-brain barrier situation. So that all can lead to dementia. We can go to the next slide. Now, interestingly, before we actually look at the next slide, there's an entity called pseudodementia. So it's actually linked to depression because of how our brains go into this very inflammatory state when we're depressed. A person can actually think that they are developing dementia. So there are several patients that will come to us saying they're not remembering actively anymore, but the way in which they're not remembering does not actually look like dementia. So, for example, someone will say, no, I'm still working, but it just feels like my brain is very slow. I feel like I'm thinking through mist. I'm thinking through clouds. And usually when we test their cognitive function, it's fine, just very slow because of the depression itself. So, bottom line, our brains were meant to be used, essentially, right? And because of that, they demand a lot of blood. But our brains thrive on a simple, nutritious diet because that will actually not injure or irritate our blood vessels. And remember, if we don't have that blood vessel irritation, then that won't promote insulin insensitivity or breakdown of the blood-brain barrier or this inflammatory cascade, right? So our brains thrive on a simple diet because our vessels thrive on a simple, plain, nutritious diet where exercise is also a big factor. Then the last point, our brains were meant to get adequate rest with good social interaction. And this is where the depression becomes an issue, because that lack of social interaction actually compromises brain health, because that social isolation, there's actually a study that looks at the social determinants of health in dementia and in depression. And because of that lack of isolation, you basically get a hypo-stimulated brain. And because of that hypo-stimulated brain state, you lose some of the pathways in your brain. So you're not using a lot of the pathways. So how we actually remember things is by telling, or what helps to aid our memory is we tell people things, we reenact stories, we think of stories, and that happens in social interactions. So if you think of it as a road, right? If we think of it as a field, this is how a brain looks, a field that has high grass. And the first time you take a walk in that grass, you've made a small little dent in the grass. After 5 or 10 people walk on that same road that you have made, it becomes a deep crevice. After around 100 people, it creates a small pathway, right? So that's what happens. The more we actually use something, the more it likely is to be embedded in the brain. So when we lack social interaction, good interaction, especially because, poor interaction actually damages the brain. So good interactions help us to retain our memories. And when we lack that because of a depressive disease, but also because of the steroid heavy thing that happens in depression, we basically lose part of our brains. So our brains need use, but they also need simple lifestyles because our blood vessels basically are dependent on that. So our blood vessels need us to have a simple lifestyle in order to ensure that the brain can get enough blood. And when there is enough blood to the brain, then we can actually keep it, right? So going to the next slide, diagnosing dementia, right? So usually what happens is that a family member brings you in. If a family does not bring you in, right, or a close friend or relative, if they do not bring you in, then chances of it actually being dementia proper are low because you do not realize that you're losing memory. So there's something we call functional cognitive decline, and this has to do with oftentimes stress or heavy emotions. It's a kind of pseudo dementia like we were speaking about earlier, and you feel as though you have loss of memory, etc., but you are able to notice it. That's not what happens with dementia. With dementia proper, you may occasionally think that your memory is going haywire, but you do not realize the significance of it. So your family notices the changes and they bring you in, right? Once again, going back to definitions, we said it was for longer than 6 months. So they usually say that these things have been happening for greater than 6 months, right? Then you should be reviewed by a neurologist. Or at least a physician, but a neurologist is better because this is our actual training. Physicians can make the diagnosis, but it is better made by a neurologist because we deal with this all the time. So then we do special tests to exclude any other causes, and we test cognitive function. So the reason we do this is because there can be many mimickers to dementia. It's a very big diagnosis to make. So you want to make sure that you're not excluding other things, or you're not under-treating someone. So for example, B12 deficiency can present with memory loss, etc., personality changes, and you may think it's frontotemporal dementia, but actually when you take the blood levels, you've actually got a vitamin B12 deficiency. Thyroid dysfunction can do the same thing. Changes in personality, memory, looks like frontotemporal dementia, even maybe vascular dementia, but in actual fact, what's going on is that you've got thyroid deficiency. Even anemia can actually, because of that haziness of memory, it can look like a functional cognitive decline. But once we take the blood, then we actually see that it's just the anemia itself. So we do all of these tests to make sure that other things are excluded. And then we must also get imaging of the brain. So either a CT scan or an MRI to see what the brain looks like. We can go to the next slide. So one of the tests that we do is called a Montreal Cognitive Assessment, a MOCA. Donald Trump was actually asked to do one recently to check his cognitive function. But basically, one of the first things that is tested in this thing is your visual spatial alignment. In Alzheimer's disease, you actually get loss of your visual spatial function, right? So you can't think of things in relation to other things. And this is why patients with Alzheimer's often get lost. So it has to do with the memory, but also the visual spatial dysfunction. So the first thing that we do is we ask you to draw a clock, and we ask you to draw a clock with all the numbers and the time. We tell you what time must be on that clock. So if we look at this slide, the first picture is a normal one. We can see all the numbers are there. There's adequate space between the numbers, and the time says 2:30, right? Now, we usually make it like 10 past 2 or 10 to 2 because that's more confusing, so it requires thought. But you can see that a person is able to plan. So you even see how they actually make this or draw this clock. So the right quote unquote way to do it would be you have 12, you add your 12, 3, 6, and 9 in each quadrant, and then you fill in the other numbers. That gives you enough planning. So that shows that your brain is still able to plan well, right? Now, if we look at the second image, that's someone's brain who's got mild or early Alzheimer's disease. But you can see the space between the numbers is not so great anymore. There's less planning included in it. Then and the last picture just shows an inability to actually even conceptualize the thing. They know that a clock must have numbers, but they can't actually tell you where the numbers must go. The planning is very poor, and they can't even think of how to make the clock look, right? So that's one of the things that tells us how things look. Then the other thing on this Montreal cognitive assessment is things like naming. So sometimes we may do it without the piece of paper itself, but at the bedside, I'd take out my keys and ask you what this is, take out my phone, ask you what this is, hold up a pen. And this naming has to do with basically your language function. Then we'd ask you 3 or 4 objects, and we'd have a conversation, then 5 minutes later test if you remember that. So this is testing memory, it's testing how you plan for things, and there are things that we look at the bedside to see how you're behaving. Are you behaving appropriately? Are you able to sit still and answer questions appropriately, or do you go off on a tangent for forever, telling us story upon story upon story until you actually forget what the question was? Are you able to develop association between things? So we'll ask you, what's the similarity between an apple and an orange? So you should be able to say that they're both fruit. So this checks your ability to actually put things in categories, all of those things, right? Then we would see if you have any frontal release signs. So this is, as we're examining you, there are some primitive, quote unquote, primitive reflexes that as our brain develops, we lose. But once our brain starts losing function, we actually start having them again. So there are different kinds, but once these are displayed, in addition to a marker, there's a score where below that certain score, it means that there is some kind of brain dysfunction combined with a CT scan or a brain scan would then tell us everything that we need to know about this whole image, right? Now that's where we go to the CT scan. So if we look at the first image is a normal scan. This is a normal CT scan. If you imagine it, it is cutting through your brain as you sit straight. It is cutting through your brain basically horizontally. So it takes pictures of slices of your brain. The first image is normal. The black portions that you see are where your brain fluid is, your CSF. That's where it sits. So the brain, although it is matter, it is surrounded by fluid to create a space of, it's actually very protective, and it also creates nutrients and stuff like that. There's a whole thing, but there's a little bit of fluid around the brain. You don't want too much fluid, because if you have too much fluid, then it means there's an issue. So there's just a little bit of fluid, and we can see that in those slits there at the brain, the ventricles, there is just enough fluid to keep the brain floating, right? In the second image, you see that those slits, this is now almost an identical slice. Those slits are now huge, right? So instead of it being just small slits, it's actually like big, it looks like a big butterfly in the center. But if you look closely around this butterfly, there's like these shaded areas of gray. Those shaded areas are not normal. Those shaded areas are where you've had small strokes or small white matter loss, right? So this can happen, mostly it happens, we see it with high blood pressure or HIV, but mostly it happens with high blood pressure, or it can happen with like demyelinating diseases, but you've lost white matter. So it's called microvascular ischemia. So small vessel that have died down around the ventricle. So this is showing us that there's been a long-standing vascular change, vascular issue, right? So because of that, now if you imagine all of those small parts are where cells used to be that have died off. So this person is already displaying some kind of change in cognitive function, right? Now, the last slide that you see, this is actually a picture of proper vascular, or the last picture that you see is actually a picture of proper vascular dementia. So if you see, this person has had multiple strokes. If you look on the right side of the picture, but the left side of the brain, but the right side of the picture, you see that there's almost a triangle of black. So the fluid, the CSF fluid, has replaced where brain is lost, right? And then you can see that that butterfly in the middle is now huge. It's no longer just a small slit, it's huge because you've lost brain volume. So the fluid is taking up space. In the right lower quadrant, there's another triangle that's gone. And then there's where arrows are pointing there. That's another new area where cells have basically died off because of another stroke. So this person has had at least 3 or 4 strokes on this image. And you can see that they've lost significant amounts of brain, right? So because of this, this person will then display changes in how they function. We can go to the next slide. So how do we prevent it? Now, the sad thing about dementia is by the time you get a diagnosis, there is no cure. but we can prevent it, right? And this is the point of this whole conversation. The fact that our vessel health is directly proportionate to our brain health. This is why the acronym New Start exists. Nutrition, exercise, water, sunlight, temperance, air, rest, and trust in God. So we need a simple lifestyle where there is adequate nutrition, where there's adequate exercise, because this promotes vessel health, water, sunlight, which that vitamin D is also actually very important for brain health, but also for mood health, temperance. And this is where there's adequate going away from that which is bad and using moderately that which is good, right? Air, rest, very important, and trust in God. And this air and rest, or this rest and trust in God, is very important in the depression aspect of it all. Although all of them have a part to play in actually helping all of the lifestyle diseases, but there are parts of each that are more highlighted in different parts, right? Then the other part of prevention is that we need to maintain good relationships. As I was describing earlier, our brain function, our brain health is linked to our social interaction because we preserve that. My husband often says that my memory is great. My memory is only great because I talk a lot. I've been speaking since I was 9 months, according to my mother. So I tell the same story at work, at home, church friends, home friends. So because of that, your brain is able to retain more. So once we retain good relationships, where we're able to speak about things, that also promotes good brain health. So once you are diagnosed, there is not much we can do in way of medication or anything, but it's going back to these principles of New Start again, going back to actually trying to preserve the little that we have. And with this, good relationships, especially relationships with kids, surprisingly. So we often encourage that patients that are diagnosed with dementia should actually stay with grandchildren, etc., because you start to relearn what you were losing by trying to teach it to your child. And because children aren't judgmental, it's great to have around. So all of that, the prevention is really where it's at. So that is the end of the presentation. It's been a lot of a technical presentation in the sense that we've gone through a lot, but ultimately it all goes back to the fact that God has really made ways to preserve our brains, to preserve our health. And this is why 3 John 2 is so important, that, beloved, I wish above all things that you may prosper and be in health, even as your soul prospers. So our souls, our minds, God wants to keep them all active and ready and good in order for his use. So I'm going to open up to questions at this time.
It is Moses. He has unmuted himself. Do you have a question?
Yes, I do. Can you guys hear me?
Yes, perfectly.
Okay, thanks. Hi, everybody. Just a quick question on the relationship between cholesterol and dementia. The reason I'm asking that question is because there's a lot of hype around, reducing cholesterol, but I've just come to learn a couple of months ago that cholesterol forms the backbone of a lot of the hormones that our bodies produce. So things like estrogen, testosterone, melatonin, serotonin, etc. But it's also a vital ingredient in terms of brain cell maintenance and so on. So what's your take on that? There seems to be conflicting information. One hand seems to say that we should reduce cholesterol, but on the other hand, it's required for all of these other bodily functions.
Okay, so there are different kinds of cholesterol. So the good kind, it's usually classified as good versus bad, but the technical term is LDL, which is the bad one, and HDL, which is the good one. So the good kind is actually what we use mostly for what you've basically described, the hormonal function, even the brain function. You have some fat around your nerve cells because it actually helps to propagate signals. So there is a good kind of cholesterol, and that's the HDL. But the LDL is the one that people are basically speaking out against, because this LDL is the one that actually injures blood vessels because of the density. So basically the one is high density lipoprotein, the other one is low density lipoprotein. So the low density one is the one that actually basically sits on the blood vessels and creates issues with the blood vessels. So basically what we need to do, and this is why you'll often be told to eat good fats. So the good fats are things like nuts, your omegas, which are found in nuts, your pumpkin seeds, flax seeds, and leafy green vegetables. So those provide you with HDL cholesterol. But your bad fats are the ones that are basically, it's difficult to break them down. And
the refined oils.
The refined ones, yes. Yes. Yeah. So the avocados, all of that give you the good cholesterol, but those refined ones give you the bad cholesterol. So you always want the good to be higher than the bad. But what happens with a diet that is poor is that your bad is higher than your good. And because of that, you have blood vessel health. No, you don't have blood vessel health, rather. Yeah.
Okay. So the LDL, does that not get transported to the brain? And the HDL seems to be transported to your liver, where it gets broken down or converted through process of methylation. Gets converted to bile, which is used to assimilate and break down fat. So I'm not sure on the LDL, because there seems to be another form. I don't know if I forget what it stands for, but DLDL, and they say that's the one that actually contains a sort of a deformed fat molecule, which comes from your refined oils. I'm not sure if you've heard it's something similar, but there's basically starting to find that the LDL is actually not as bad as what they originally thought, but it's rather the other one that I mentioned that is bad for you.
So even the simplification of just LDL and HDL is a bit of an oversimplification, but it's just for use, right? So you have even your long chain fatty acids. You have many fats in the brain. So both your LDL and HDL are broken down by your liver. But in fact, most of your fats are broken down by your liver. And then it is transported, all of them, to the brain. But you basically need it to be in a ratio of good versus bad, right? So the issue with the diet that we're speaking of is that your bad outweighs the good. And that's the real bottom line to it all. You will never get to a point where you have an LDL of 0. That's just purely abnormal and wrong, even for the body, because you do need some fat to do other things. So you do even need the LDL, but you need your LDL to be lower than your HDL. You need your fatty chain acids, your triglycerides, to be low, because those are the ones that are basically your free fatty chains. So it's a bit of an oversimplification to just put it in those two groups, but for the sake of clarity, it's basically to reduce the bad so that your good can overpower, basically, because the good one is the one that we actually can use, whereas the bad is basically just deposited in cells versus whether fat cells or nerve cells or even blood vessels themselves. Yeah, so those ones actually impede actual function.
Oh, okay. That makes a lot of sense. Thank you. Thanks for clearing that up.
Sure.
You can go ahead. Moses, you can go ahead. Hello.
Hello. Can I? Hello.
Yes. Go ahead.
Hello. Can you hear me? Okay. Good evening. How are you? I just wanted to ask, because I am. I was firstly diagnosed with anxiety and depression 2013. And then I believe by good relationship in trusting in God, it just took me a few months, then everything was cut off. I no longer had anxiety and depression. Like 6 months after that, that I was diagnosed in November 2013. like 6 months later, around June the following year, there was no more anxiety and depression because I gave it all up to God through to a Bible study and a prayer session. And then it came back, boom, in 2023. Yeah, it came back. And then I was diagnosed again. No, it was 2022 that I was it's like a, what do you say, a rebound or something like that. That I was again having there was anxiety and depression. But I believe that as it went on, I started learning through the courses, through the psychiatric sessions that we had, occupational therapists, psychologists, and psychiatrists that I got to help myself through the help of God, once again through those people as well that helped me. I no longer suffer from depression. I'm only left with anxiety, which I get sometimes anxiety attacks every now and then. And then I was hospitalized now in May month because of anxiety. And then I was hospitalized now again in actually this month on the 5th. I was hospitalized once again. So the doctor talked about my sodium levels that has dropped and so on. So I believe what happened that I've inhaled smoke that caused me to vomit. And then I vomited a lot of good stuff out, like my electrolytes and my sugars. So I believe the reason I've lost a lot of sodium in my blood through vomiting, because every time I vomited, I drank water, vomited again, so on, until my kids were here with me. My wife was not available, but she was visiting at home, and then the kids called neighbors and so on. The neighbors helped me get to call the ambulance. The ambulance came, and then it picked me up around 8 o'clock. I woke up in a hospital. They told me that I was in ICU on the 5th, and then the 6th, they moved me from ICU to the normal ward for recovery. Then the doctor came and visited me and told me that I must take it easy on drinking water. But I was having now a dilemma because I drink anxiety and depression tablets and sleeping tablets. Why would I now take it easy on water? Because those medication actually requires me to drink a lot of water. So I got a blackout. Yeah. The reason why I'm so concerned about dementia is because I got a blackout. So I thought that blackout, can it be that I've lost a memory? Can it mean that there was a clot in my brain somewhere that happened, that I somehow got this episode again? So yeah, my question is up to that far. I mean, my explanation, my question is just about, is it possible that there could be something close to a dementia or not? Thank you.
Can I just ask, what was the nature of the blackout? What do you mean when you say blackout? What happened? Brother Moses?
Okay, I just unmuted myself, sorry. What happened? There's this gestures that I've made. My daughter don't understand what I've made. I first fell. She saw me falling, and I didn't want to give up, because my responsibility in the house when my wife is not around is to make sure the children have hot water in the bath and there is clothes ironed and stuff. So if I didn't iron the night before, I ironed early in the morning. So I wanted to iron. It started there where I wanted to iron my clothes and their clothes as well. And then I couldn't finish ironing because I had a plan scheduled in my head. After ironing, I'm gonna prepare my lunch, and then this and that. So the salad bowl or the salad bag, the salad bowl fell out of my hands while I was trying to prepare for my lunch. So after it fell, luckily, thanks to God, I didn't fall on the glasses that broke. I felt something like backward when my son called to people, then they came to help me up. And then I had two colleagues of mine that came from far to come and pick me up. They picked me up and then they led me to the sitting room. I sat on the sofas and then we were waiting for the ambulances. And they say, all I could say, God is good. And when they say all the time, I say, as you see, there was an interaction with them, but I don't remember that. The only thing I remember when I woke up is that I saw a blurry vision of it's not a very blurry. It's like I saw my daughter blurry, but my son, I saw him very brightly. But the thing is that just after I saw him, I started vomiting. So it seems like just when I started vomiting, my mind just lost me. And then things happened spontaneously. I was no longer thinking on my own. My body was just reacting towards people or some or objects around me. So that blackout, that I think that blackout, can it be also sort of by dementia? Because I heard you say we should go to scan, MRI scan, and so on, that we can really see the graphics, what happened there. So,
Okay. So yeah, no, it doesn't sound like dementia. So remember, if we go back to the definitions, we said that dementia is chronic, right? So it's chronic and progressive. So you had an isolated incident where it sounds like you had a loss of consciousness, maybe linked to your low sodium. Not sure if it was a seizure or not. Don't want to say because I wasn't there, but it sounds like you basically had a episode of loss of consciousness. So essentially, just like when you're sleeping and people are doing things around you, you don't have recollection of that. It's a similar thing. If you have an episode of loss of consciousness, you won't have recollection of that episode. But it's not dementia because it is an isolated incident. It's non-progressive and it's not chronic. So because of that, it's not a dementing situation. It sounds like it was linked to your electrolytes that you had that episode of loss of consciousness. So I wouldn't be worried about dementia. Yeah.
Oh, thank you very much, Palesa. Thank you very much.
Thank you so much, Brother Moses. Are there any further questions? Okay. Dr. Palesa, thank you so much. We really learned a lot this evening.